Hi, everyone. Welcome to the Rural Learning Collaborative. My name is Shannon Robshaw. I'm with the TA Network, and we are excited to have Katie Hayden-Lewis with us today from the Oregon Health and Science University. I had to look at my notes, excuse me. And we're also happy to have Christina Paternoster here as a co-host with the Rural Learning Collaborative. And we're trying webcams today, as y'all can see. I was kind of a last-minute decision, but we'll see how this works, and we're hoping Katie will be able to stay on camera during her whole presentation. We think that'll make it more engaging, so we're going to give it a try. So welcome to everyone. We'd like to take a poll to figure out who is with us here today. If y'all could please respond about your organization. Let's see, there we go. So private providers, state or territory Medicaid agencies, family organizations, that's good. Can we get some more responses, please? We've only got 5 people responding. We've got 20 on the line. Please let us know who's here. State, tribal, or local mental health agencies, health agencies. All right, just a couple more minutes, a couple more seconds, please. Let us know. So no family organizations after all, no youth organizations, child welfare, education, mostly just mental health. Okay, all right, well, we can end that poll, and then we'd like for you to also respond as to your role in your organization. Project director of SAMHSA grant. That's one person. We've got 20 more people. We would like for you to respond, please, so we know who we're talking to, and Katie can understand who her audience is. Academician researchers, TA providers, just one direct service provider. That's sort of surprising. Anyone else want to weigh in? Got executive leadership of an organization, supervisors. Okay, 4 direct service providers. There we go. All right. Okay, well, thank you, Tiara. Once again, welcome, and we're excited about the topic today. I also want to encourage everyone to join the Rural Learning Collaborative if you have not already by visiting Ideas at the Institute, the TA Network's website, where we have all of our learning communities housed. You can join all of our learning communities from Ideas at the Institute. Tiara will type in that address where you can join, and we have Youth Learning Collaborative, we have clinical best practices, we have a number of learning collaboratives you might benefit from joining, but we welcome you to join the Rural Learning Collaborative as well. And we would ask you to please stay on after Katie's finished with the presentation for a very brief survey so we can get your feedback as to how it went. We would also welcome any suggestions that you may have for topics in the future. You can contact me directly. I am right there, Shannon Robshaw at ssw.umaryland.edu. So I would welcome any feedback directly or any suggestions for future topics. And again, thank you for joining us today. All right, and I'm going to turn it over to Katie. Katie, thank you so much for being with us today, and I really am looking forward to hearing from you.
Thanks. Hi, everyone. Thank you so much for joining us today. It's really a pleasure to get to talk with you all about the work that's been going on in Oregon and the rural and frontier communities. Again, my name is Katie Hayden-Lewis, and I work with the EASA Center for Excellence, which is housed at the School of Public Health at the Oregon Health and Sciences University. I happen to be on the East Coast today. I typically live in semi-rural Oregon, though. I live and work from a much smaller community than the one I'm talking to you all from today. I have some learning objectives. They might be lofty, but maybe not, and I'll just go over those. So my hopes for folks joining the call today is to be able to identify 3 implementation areas to consider when you're adapting your coordinated specialty care programs into rural and frontier communities. Implementation and adaptation, I'm going to talk quite a bit about that on today's webinar and what's worked and lessons learned from Oregon so far. Next objective is to learn 3 potential strategies to support implementation in rural and frontier communities. And the last is I'm a big believer in taking action after we learn, and what I found is committing to, when we can think about what's, after we learn some new information and share knowledge with each other, what's one step that you might be able to take to support effective implementation or effective clinical care in the rural and frontier communities? So that's a call to action. I'm a big fan of call to action and also keeping it right-sized. So here we go. Let's see. Whoops. So I'm wondering if folks wanted to share what you hope to learn today. I put out some objectives. I'm really curious what you're bringing in. Even if it's one piece you're hoping to learn today. And go ahead, and I think you can type that in so that I know and we can all kind of see what we're bringing in as a group. Great. Pros and cons of different models or model components. Okay, great. Great question. Thank you. Anyone else have a hope of what you want to get out of the webinar today? How to combat stigma in rural areas. Wow, yeah, that's a huge one. Thank you for bringing that up and bringing that to our attention and my attention. Yeah. Model. Great. Okay. Practical strategy for expanding programs to new sites. Great. Thank you. Ideas for providing services in rural areas, especially related to staffing, engagement. All right. Key ingredients for success. Fantastic. How to help rural communities that do not have access to an FEP program. Wonderful. Okay. Great. Thank you. I've made a note. I think that we could probably have a summit on rural and frontier implementation. Some of your questions I'll probably tap on what I've learned from doing this work in Oregon, and some of the questions I think are far more complex and they're questions I'm sitting with myself and hoping to learn more about. Thanks for being willing to put that out there to the group. Appreciate that. So first, talk about the larger context of Oregon's early psychosis programs, and then I'll move us more into the specifics of what's gone on in the frontier in Oregon. So in the United States, there's been this massive explosion of coordinated specialty care, growing the number of these programs all over the country to address and help young people with early onset psychosis. There are a number of successful early psychosis models available. There's been fantastic research that's been done to validate the effectiveness of different programs and some of the components of the programs. However, within the context of the larger growth, there has been less exploration around how to adapt and implement coordinated specialty cares, specifically in rural and frontier communities. So this presentation is going to highlight the adaptations that I have led Oregon's EASA Center for Excellence and Oregon's Rural and Frontier programs into using to see how we can go after getting equity of access to service to our rural and frontier communities. The adaptations that we've experimented with in Oregon and the ones that we're finding to be effective include cultural understanding of the communities, evaluation of technology, both access to technology as well as technology culture, high-tech culture, low-tech culture, looking at staffing patterns and how programs are typically staffed. Typically they're role-driven. I'll talk a little bit about more how we've had to change that in Oregon. Issues and access to training, access to services for direct service providers, how to do community outreach, who to do community outreach to, what mechanisms to use in rural and frontier communities, questions around engagement, and then how do we evaluate and mobilize existing resources to support the effective implementation of coordinated specialty care programs. And specifically, I'll be talking about EASA because that's where almost all of my work has been done with the EASA programs in Oregon. Moving into Oregon, before I go into the, what you see on the slide, I really want to acknowledge that the work that I've led in Oregon has been highly collaborative. It wouldn't be possible without the innovation and expertise of the EASA Center for Excellence team, without the support of the Oregon legislature funding and the Oregon Health Authority. And really, the success of this work belongs to the incredible investment of our rural and frontier providers to go ahead and take a model of care that was designed mostly for urban settings, the EASA model, and be really innovative and try and figure out what's going to work within their own communities. So that means being willing to succeed and being willing to fail and being willing to evaluate as transparently as possible those efforts. So this Oregon story really belongs to the rural and frontier communities, and it's been a great honor of mine to get to work and support the providers and leadership in those communities. So backing up, Oregon established an initiative to provide Oregon to EASA in every county in the state. So right now, we starting in 2012, the EASA Center for Excellence took that initiative as a priority focus to go ahead and take the original programs and then the secondary level of expansion of EASA programs and offer an EASA program in every county in the state of Oregon. Very exciting work. In 2015, the Oregon Health Authority, who's our contractor and funder, as well as the Greater Oregon Behavioral Health Initiative, which is the coordinated care organization that oversees most of the rural and frontier community mental health programs, and the Center for Excellence decided to create a position specifically designed to support the effective training, technical assistance, and ongoing consultation for the rural and frontier communities. That position is the Rural Services Director. That's the position I was asked to take. So I have been sitting in the position of Rural Services Director for 4.5 years. Prior to that, I had established a tri-county, semi-rural and rural early EASA program, and I did that for about 7 years. So I've been involved for a while, and then there was a need to really prioritize support for the rural and frontier communities. Geographically, we're talking about half of the state of Oregon. Population-wise, not even close to half the state of Oregon. So there was a real desire and capacity to invest heavily in what is a low population base for the treatment services and this work, which goes a long way. So a lot of what we've been focused on in Oregon is developing and implementing, building partnerships, adapting clinical training, looking at program implementation, and finding ways to effectively deliver ongoing technical assistance across 7 sites that are serving 10 counties. So that's the sum of Eastern Oregon. Many of the communities in Eastern Oregon are accessed on 2-lane roads. Some of those roads are impassable or semi-impassable during inclement weather. And many, many areas do not have Wi-Fi or cell service. So we could not rely on technology to cross the barriers, both the access for training and technical assistance barriers, but also some of the barriers that come from me and the Center for Excellence, which were not housed on the frontier, from outside the community support folks. The funding, I think, as I mentioned, was made available through the Oregon Health Authority and is managed through Gobi. Most of the sites that receive funding on the rural and frontier communities got about 0.2 FTE, so they received funding to staff 8-hour-a-week position with some additional dollars set aside for training. And if you see, I love these photos. This is where I get to go work. These are images from 4 different counties in rural and frontier Oregon. So this is where the work is happening. Very beautiful place. And place and geography is very important to our communities in Oregon. I feel very tied to lifestyle out there. There were a lot of adaptations that needed to be made in Eastern Oregon. So one was, and the priority again was to provide equitable support to our rural and frontier sites, and then sites who are a blend of rural and frontier communities. I'd like to look at the definition of rural and frontier. I didn't know when I started in this position that rural and frontier were considered different by a lot of people. So I was educated about that when I was doing some technical assistance out actually in Wallowa County. Wonderful, I see we've got someone from Wallowa on the line here. So in Oregon, a rural community is defined as any geographic area that's 10 or more miles from a population center of 40,000 people. So 10 or more miles is rural. Frontier is a county with 6 or few people per square mile. So we're talking about different community areas, and I like to honor that people in those communities sometimes aren't identifying as one cluster. We're not all rural, we're not all frontier. There's different compositions and different considerations, both in lifestyle, values, relationship to mental health, access, equity. There's different community structures. Okay, implementation challenges. There were a lot when we got started. So there was no, although EASA has, we have practice guidelines and we have collective, many years of collective experience with successful implementation of EASA programs in Oregon, there was no historical precedent to look to for adapting coordinated the EASA programs into rural and frontier settings. So we had a map, we had practice guidelines, we had experience for implementation in urban and semi-rural areas, but we didn't know how to do this yet in our smaller communities. There was also really needed to have somebody that knew EASA, that could also go into the communities and engage directly and build relationships directly face-to-face and in the room with community leaders at the mental health agencies and with the care providers. This wasn't going to be done successfully going out once a year to someone else's community as an expert and imparting knowledge on that community. There's history around that not being effective. That's the feedback I've gotten from our rural and frontier partners. More working to embed as much as possible in person, investing time and resources to demonstrate commitment to figure out how to make these programs work. It was also really important to look at the programs through a resiliency and capacity lens rather than because they're so small they're going to need to do less effective work or they won't be able to do as much good work, really needing to shift the thoughts around how we approach the work. Another big piece was most of EASA programs have a very robust and fantastic transdisciplinary team models. Our larger programs have probably anywhere from 5 to 9 to 10 different providers on the team. Some might have overlapping professional background. Other folks have unique specialty focus. On the frontier, can't really justify having a 6-person team when you might have a 3-person program as far as your N or the number of people enrolled in the program. So needed to look at our existing successful transdisciplinary team model and move away from talking about we need these roles fulfilled and looking more at what are people doing, what are the tasks involved in those roles, and who on the team, a team of 2 people, 2.5 people, who on the team can get trained and be responsible for offering the services and paying attention to the tasks that needed to be done. So really needed to do a shift. We also needed to continuously evaluate how much time and what kinds of resources this was actually going to take, and supporting agencies moving away from thinking about staffing a program once you have enough clients to justify staffing the program, and moving towards the program initially is our client. The program is what we are serving when we're starting out with implementation. And so protecting time and resources to really look at the infrastructure of the program and really invest just as we would with the care of somebody that we are supporting in treatment. Lots of work, lots of work. More challenges. So needed to consider these different geographical the geographical impact on accessing technical assistance, on how the Center for Excellence delivers training. Historically, trainings have been offered in metro areas. That could be up to a 9-hour drive each way for some of our frontier providers. Another piece was looking at the individual placement support model, which is a fidelity-based supported employment model. There are not a lot of IPS certified fidelity workers out in the rural and frontier communities. We needed to take a look at how could we honor some of the fidelity components and get the good outcomes from IPS, but also acknowledge that there may not be an IPS certified worker to provide supported employment, and also knowing that in coordinated specialty care work, some of our best outcomes are derived from rapid access to employment support, and now we're looking at rapid access to education support. The goal of the programs initially were to meet full fidelity and replicate staffing on the same timeline and with less funding as more urban programs. That didn't work at all. So that was a big challenge. And then EASA practice guidelines were written and implemented at a time where there weren't frontier programs. So the way our practice guidelines are organized and the language in the practice guidelines and the recommendations in the practice guidelines had not been adapted yet to rural and frontier communities. This led to some really difficult work in the beginning. EASA performs fidelity reviews based on our practice guidelines every 2 years. When I led all of the fidelity reviews for Eastern Oregon, I have for the past 3 years, and it was very difficult to go in and look at a rural and frontier program, evaluate them based on really solid practice guidelines, really good evidence base in there, but with lack of consideration or knowledge about what kinds of resources and adaptations the sites would need to implement a fidelity model. And so I had the very uncomfortable job of not passing every site in Eastern Oregon when they went through a fidelity review. What that resulted in was extensive technical assistance and quite a few adaptations my team at the Center for Excellence has made and continue to make in order to rectify that imbalance. So I actually want to pause and just see if there are any questions folks have before I keep going about any of the content that I've shared so far. And I think you can put that in the chat box. Okay, I'll keep going. So another question for the group. I'm curious what you would add from the first episode psychosis work you're already doing in rural and frontier communities around implementation barriers, considerations you've made. I think you can go ahead and type in. Okay, well, I'm not seeing anything added, so I will take that as we're thinking about it, or yet to be done, or I'm covering it all. I'm gonna go with thinking about it. Can't imagine I'm covering it all. There's so much to learn. I feel like I'm just beginning myself. So what did we do? Initial steps to address some of the challenges that I just talked about. Really needed to adopt an experimental and growth mindset. This was difficult work. Not passing fidelity reviews, not having a map to rely on for rural and frontier implementation. Very difficult work, so it's really important to be learners, to think about what are the lack of successes, what are the failures pointing towards what we need to be doing. What does that mean? What structural changes need to take place? So really leaning in. Let's see, I'm going to just pause. Kayla says, I'd like to know how to simply get the programs there. I do not think we have any rural communities. Okay, Kayla, thank you for that. Not quite sure I could answer that specifically, but maybe we could do some brainstorming. Initial steps to address challenges. So needed to move, we moved the funding for the position I am in from the Coordinated Care Organization to the Center for Excellence. And so the idea was that the Rural Services Director would be the bridge, would be the advocate, would be the lead adapter representing rural and frontier communities. So almost like being an ambassador that needed to consider the fidelity models, technical assistance needs, research, and then what in real time the rural and frontier communities were saying that they needed to make work. That was a big shift. They had site-by-site evaluation, so this involved going into each of the sites in Eastern Oregon and really looking at, for their community, their structure, their resources, how people do and don't access mental health services historically, in order to inform a very specific implementation plan for their community, and then to adopt that the implementation plan was experimental because no one had done it before in their community. So really a lot of attention and time placed on evaluation and discussion and review, comparing the fidelity guidelines with what implementation was working, what programs could we look to, like a wraparound program or assertive community treatment program could we look to if they had been successful in the community to draw on for EASA. Lots of time. And then absolutely, I don't think this is unique in rural and frontier communities, absolutely have to have protected time to focus on implementation. There's just no way to have a program take root in a community unless it's got the foundation to do so. So really needing to work and adjust around that. And I know that's not unique to rural and frontier communities. More initial steps we took, really looking at to build equity for access and service delivery around vast geographic regions. So for example, I was just talking with a frontier provider, I think it was the day before yesterday, who's covering 4 frontier communities. She happens to have 32 hours a week because the 4 counties combined their FTE, and we talked about how they had been working to implement a 6-person team across 4 counties because they thought that that would increase equity and access. Not quite sure that's happening right now, and so she and I were having the conversation around it could be that a large chunk of your 32 hours is involved with driving to see people across these 4 counties in order to ensure equity, of services, access, and also equity of community education and outreach. Also, this is ongoing, identifying the needed technology to meet with folks. I'll start with a success. The success is when I started out providing technical assistance online. We didn't use webcams, realized the webcams were really important for rapport building and community building across our frontier and rural providers. Many of our community providers had not used webcams, had not used platforms like this, had not been involved in ongoing technical assistance in group or individual or site-specific settings. So needed to problem solve, just getting a webcam at the agency, getting a webcam for the computer. I know it's a small task item, but it was pretty significant, particularly in communities that don't rely necessarily heavily on technology to get the work done. one of the things we're needing to evaluate ongoing is how to provide, what technology are folks going to need when they can't come into the clinic. I'm not quite sure we're going to problem solve that soon, but that's something to pay attention to. So looking at Wi-Fi, self-service, and then this piece that I'll refer to, which is low-tech and high-tech behaviors, when we're looking at technical assistance, service delivery for community members, maybe are not high-tech folks, are not high-tech users, maybe that's a values-driven thing, decision, maybe that's an access issue. And then really one of the steps that we've taken and continue to take that I think the Center for Excellence is really good at is really soliciting ongoing feedback, asking for feedback from our community providers. What's working around technical assistance? What's not working? What's working in your service delivery? What's not? What kind of trainings do you need? How do you need those trainings to be delivered? Coordinating group meetings, working with leadership, and then again, taking a look at the pattern of fidelity scores being incredibly low when we go out to do reviews, and taking that as direct feedback to the Center for Excellence to really need to prioritize adaptations. First, adaptations we've made in training. Move the trainings from being metrocentric and offering them in Eastern Oregon. Offering them in communities, offering them, if 5 people are going to show up to a training, that's great, that's 5 people. We're not going to wait for 30 people to register to launch a training that the providers really need to do the EASA work. We're going to go ahead and train folks that show up. We wouldn't have 30 people. There's only 22 providers in half the state in the first place. So really just saying it's not a numbers game. We got to get the training more accessible. We need the trainings to take up less resources and less time and be efficient. Some of our other trainings, so we have specific trainings that are held in Eastern Oregon. All of the statewide trainings that the Center for Excellence offers now works to rotate around the state. That's something I learned from the rural and frontier communities, is they wanted to share the responsibility of driving to different people's communities to get together for trainings, and so we brought that to the Center for Excellence. So some of our core trainings, our introductory trainings, our structured clinical interview trainings, our SIPS trainings, we're moving those across the state of Oregon so that everyone can share in the responsibility of needing to take their time to drive to receive trainings. We've developed web-based recorded trainings and also offering hybrid versions of some web-based training. For example, in our family psychoeducation, I do a 4-hour live training followed up by a 1-day in-person skills training. And I actually schedule those trainings so that it's possible that folks could drive maybe 3 or 4 hours and attend the training the same day and then go home to honor the considerations around resources. We are reviewing and refining our training objectives to match prioritization around what do folks need to know when they're first getting a program started, what's the content they need to know, different from maybe moving towards advanced or mastery level content trainings for EASA. And then also really encouraging rural and frontier providers to invite their non-EASA staff to our trainings. There is room in our trainings for folks. We want to saturate the agency, saturate the culture, and saturate the community providers with knowledge about EASA in the event they need to step in the event there is high staff turnover, or in the event that they're going to work as an adjunct to someone receiving EASA services, offering services that the team doesn't receive, but not a full EASA person. So really opening up the learning platform for folks. Staffing pattern. Needed to move, as I mentioned earlier, to a task-driven rather than role-driven team composition. An example of that is EASA has a number of services typically provided by a nurse. There are not enough nurses in our rural and frontier communities. They're in very high demand, and so one of the tasks that we needed to take on at the Center for Excellence was really looking at what of the tasks that are typically provided by a nurse could somebody that was knowledgeable in those areas provide, the services they could provide related to the task that wouldn't rely on a nurse. So coordinating labs, does not rely on a nurse. Somebody on the team might do that. An additional example of that is after talking to several of our Frontier licensed medical providers, a number of them gave me feedback saying that what we're asking people to have a nurse complete are actually some of the roles that our Frontier medical providers, some of the tasks our Frontier medical providers pay attention to just because of how they do their work on the Frontier. So we've come up with some staffing recommendations around how to look at something like the nursing role and the nursing tasks and consider to have licensed medical providers covering those tasks, other team members covering those tasks, in no way trying to minimize the value of nurses, but being at the same time being very realistic about resources, and even if those staff people are available, nurses are available to work in EASA. Attending to vulnerabilities with staff turnover, some of that again is saturation of training, really encouraging people that are not EASA official staff to attend our trainings as much as possible. Ongoing evaluation for protected time. I gave an example a couple minutes ago about focusing on program infrastructure and implementation. Really considering drive time. I don't think that I haven't seen staffing ratios and recommendations that consider how long it takes to drive in some of these Frontier communities to see someone in person. And of course, the EASA programs are community-based. They're offered in the home, in the community, or at the mental health agency. You might drive 2 hours one way to go see somebody. So that needs to be considered when looking at caseloads and funding, of course. And then also encouraging the IPS model to be in place for supported employment, but not requiring it from our EASA programs, an important adjustment that we've made. Ongoing technical assistance. So the Center for Excellence offers technical assistance across most of the services, supports, clinical interventions that our teams are providing. Right now in Oregon, we have several of us that lead technical assistance for the state. We've divided the lead up based on region. So my region is Eastern Oregon that I take the lead on. We've moved to video conferencing platforms rather than call-in only. Again, people are looking at each other. There's time for some of that social rapport that's built through nonverbal communication to occur, particularly when the Frontier communities are not meeting monthly in person. It's not realistic, it's not feasible, it's not sustainable. So we really rely on the video to create relationship and collaboration with one another. We offer the monthly video clinical consultation calls on the SCID, the SIPs. Our licensed medical provider offers a call. We have a leadership call. We have a call for nurses, and we have an occupational therapy call. Needed to work to figure out what time was going to work for folks. Just very logistic but practical. We actually in Eastern Oregon have 2 time zones we work with. And it's really important for equity to consider everyone's time. And if I schedule a call at 4 o'clock West Coast time, I'm automatically excluding one of our sites from being able to participate because they're an hour ahead. I know that that's small, but I think that it's really attention to those kinds of details that communicate equity and will promote access and hopefully transfer into equity and access of care for the young people, families, and supporters enrolled in our programs. We try and offer continuing education units wherever possible with our trainings, with participation in our calls, and ongoing work with sites to obtain and learn how to use technology that's going to meet their needs and the needs of their community members. One of the innovation that I'm very excited that we've established in Eastern Oregon, we're going on our 2nd year, is we have established quarterly regional in-person all-day learning collaboratives. That means that the folks in Eastern Oregon, I think we've got about 85 or 90% of the EASA team members' attendance come together. There is a host or hostess site in Eastern Oregon, so that's sharing the drive responsibility to show up in the meeting. The meeting lasts all day. There was funding, the CCO, Gobi agreed to support the funding for people to be able to participate in these in-person all-day meetings. And we have the meeting structure set so that in the morning we have many training topics that we focus on. Those training topics are a combination of feedback I've received directly from folks around what they want to learn more about around EASA. That could be an intervention, family engagement. We just had one on the clinical high risk for psychosis group. We've had them on young adult participation. So it's a combination of feedback. It also I take a look at and evaluate patterns of need based on my ongoing clinical consultation calls. So if I keep hearing people talk about they're struggling with family psychoeducation or they're struggling with a certain aspect of differential diagnosis, and I see that as a pattern, I'll take that as a consideration to be a learning topic at one of the collaboratives. We have met and learned and talked more about how to do strengths assessments. So the morning portion is a learning topic, and then we break for lunch, or we have a potluck, which is really nice. And then we come back in the afternoon and we have 3 hours of clinical consultation. The clinical consultation prioritizes applying the content from the morning to case presentations. Or I always tell folks, if you don't have something, let's just talk about your work, and I'll sort of guide them to present. I also really encourage folks to present on wherever they're at developmentally. So if somebody is a new program in Eastern Oregon and they're working on community outreach and education, then I encourage them. I say, well, and we're talking about the clinical high risk group, then we just want to talk about, during their consultation time, let's talk about how you're thinking about presenting clinical high risk in your community. What kinds of barriers do you think you'll come up against? What kind of resources exist or supports or values exist in the community where this message will go over well with community members? The presenters to date have been members of the Center for Excellence team, so it's a great way for me to bring my colleagues that have less direct ongoing contact in rural and frontier communities into the room, build rapport, provide their knowledge, mastery, and expertise, and support to the rural and frontier communities. Definitely important to have more than my lens in the room. I've just got one, but I work with fantastic colleagues. You can see some of the learning topics I have listed here. And then again, folks really wanted to share the rotation, share the load of travel, and actually really enjoy hosting. Typically, folks are bringing in homemade food, they're offering breakfast, and they get to share lodging and activities that are unique to their community with everyone that attends. So it's been really great. It's one of the highlights of this work for me. Let's see. So moving further into talking about how I talked about our practice guidelines earlier. So just to set the tone, the EASA practice guidelines were developed by a cohort of EASA team members and key stakeholders from across the existing statewide programs, implemented across the EASA programs in 2013. That's when we published the guidelines. They were built off the Australian guidelines. Again, as I said earlier, there were no frontier programs at the time of the guideline development, so some of the language and some of the recommendations that the practice guidelines point towards couldn't possibly consider rural and frontier adaptations. So going to what I spoke about a little bit more in depth. So as we had sites moving through in rural and frontier communities, moving through the fidelity reviews and repeatedly not passing, some of them meeting maybe 50% of the needed 80% when we went in, really took that to heart at the Center for Excellence and did a very deep dive into what kind of feedback was that giving us. Because going back in and sending the message, even if it was inadvertent, to try harder, to think smarter, to be more resourceful was ineffective. And so what we needed to do at the Center for Excellence was actually think smarter, think more innovation. What is this feedback? People not passing, what is that feedback pointing towards? And what it was pointing towards is we needed to shift. And we needed to take our look at our practice guidelines and look at that EASA is an implementation model. And there are probably stages of implementation. I know our director, Tamara Sale, made the recommendation for us to use more implementation science approach to the practice guidelines and the fidelity reviews, brought in language around taking a developmentally informed perspective to program implementation. So starting in about December of last year, January of this year, we took a deep dive and we started to walk through all of the practice guidelines for EASA. And what we did is we went through, we have 16 practice guidelines. Within each of those practice guidelines are target elements, objectives, and each of the practice guidelines get a score for how a site is performing. What we did as a core Center for Excellence team was we took a look and identified at what would be the first step for implementation for an EASA program. Because implementing 16 practice guidelines all at once within 2 years and passing fidelity clearly, again, was not working. So what does the program need to pay attention to set the foundation for longer-term success and sustainability? And we went line by line. We agreed and we disagreed, which was really important so that we could get clearer around our perspectives based on our experience and knowledge around what programs needed to do to really get embedded in their communities, to really be owned by the communities, and then succeed and have successful outcomes. So we've done that. We are at the first stage of rolling out this project, which I've named the Benchmark Project. So now we have taken the same practice guidelines and highlighted what is a level 1 or benchmark, what should be level 1 or benchmark foci for newer programs or programs that have repeatedly not passed a fidelity review. So now we can point people towards, out of all of the 16 practice guidelines, there are a lot less elements to look at to really get your program in place. Granted, if you had all of those elements in place, I think you'd score about a 54 or 56%, but we're less focused on meeting an 80% threshold, less focused on kind of black and white pass-fail, and more focused on, look, if we develop this well, if we build it well, then you'll get the good outcomes over the longer term. So let's look less at the number and much more in implementation, and then reward the implementation, saying, look, you reached benchmark, that's fantastic. What that probably indicates is that you've set the foundation for a successful, sustainable program that's going to deliver some really fantastic outcomes for your young people. We then went through and we have a level 2. So once you've achieved benchmark, then we have level 2. So when people have the benchmark elements in place, what's next? What should they be looking towards next? EASA is always looking at what's next. What's the next either innovation or what's the next stage of implementation for the program to succeed? We didn't want to jump from a 54 or 56% to an 80%. That seemed like there would still be a gap based on the number of sites that were also achieving maybe a 72 or 73%. So now we have some recommendations, and once you've achieved benchmark, we want you to take a look at level 2. And we want you to start to look at those elements and implement around level 2. And then we have clear what's full fidelity threshold, reaching an 80%. So very exciting work to be rolling out. We just getting it out there in the past couple of weeks, actually. I did my first fidelity review using the benchmark tool, which reduced some of the stress and anxiety around folks worrying around getting an 80%, and we refocused the purpose of our technical assistance around building a sustainable model for their community, and there was a lot of buy-in around that. Another frontier community using the benchmark project, it was, and I had heard already from their executive director concerns around investing resources in such a small program. It was actually really helpful to flip through practice guidelines that were not level 1, that they didn't need to focus on right now. And there were a lot of smiles in the room saying, let's take it one step at a time. What do we need to do in the next 6 months? What do we need to do in the next 8 months? So there's a lot more buy-in, and I think it keeps the goals very realistic and attainable. This is more a slide on what I've just been discussing around the benchmark project. There are some ways that I think we can evaluate the success of this, what's the purpose of the changes. We're just starting to educate the network about how to use the tool. We did hear from one program that's achieved fidelity for 10 or 11 years that they were actually using the benchmark tool to refine their own strategic planning. What do they need to do next? Even though they're a full fidelity program, what else do they need to pay attention to? Or what might they have forgotten along the way that's benchmarked that they need to start to implement? We're going to need to make sure all our fidelity reviewers are familiar with the tool, the purpose, how to use it, and then looking at those intended outcomes. And then I like these secondary outcomes, like reducing stress, improving strategic implementation efforts, move towards passing thresholds sooner with greater ease. So there's a lot more clarity with being more concrete and specific around what to focus on. Some unanticipated gains. Again, our Center for Excellence team really needs to go through and come to agreement and shared understanding around our own practice guidelines and fidelity processes. The capacity to protect the benchmark items is increased because we've identified them for our sites. I think that we're going to start to take a look at our current training and make sure that our own training content reflects benchmark level 2 and full fidelity programming. So if we're doing an introductory training, we're going to want the content to be sure it's matching up with achieving the benchmarks. I discussed the LMP recommendations that we've come up with, and we're continuing to take a look at and refining with our occupational therapy lead at the Center for Excellence, Tanya Newer, how to offer sensory-informed services that are informed by the field of occupational therapy, but don't rely on having an occupational therapist, because I believe there's only one that works in mental health in Eastern Oregon. So what's still missing? We don't have exact timelines of recommendations for how long we think it'll take sites to achieve benchmark level 2 and full fidelity. I think we're starting to take a look at how long historically has it taken for sites that haven't passed and sites on the frontier. Still, I don't want to throw numbers out there because I don't feel like we got a good agreement yet at the center, but I know that's something that we're going to be taking a look at. It's possible that for community outreach and education, which is a big priority focus for a lot of the time of the rural and frontier programs, because to achieve saturation, they're going to need to cover a huge region. They're also going to need to address items like somebody mentioned earlier, stigma or really negative social attitudes and discrimination, and how those show up uniquely or similar to urban environments in the frontier. That's a whole field I think we could delve into and take a look at more. I think it's going to become more pressing to be culturally sensitized to what value variables do we need to consider, what messaging and strategies might need to be different. And then we're also just completed working with a fantastic equity researcher, Jorge Ramirez, who had some funding through the Oregon Health Authority with the Center for Excellence to look at our family engagement practices, and also doing some key informant interviews with our First Nations tribal community members to try and understand, just start to dip a toe into what are we missing. I know we're missing a lot with engaging successfully with First Nations people. So that's a whole other large project we're delving into. What's next? The rollout of the development claim fidelity tool. We have funding for those quarterly regional in-person meetings for next year. That funding, I don't know if it will be continued. It's just a drawdown fund right now. Those meetings are incredibly important to the health, well-being, and I think regional sustainability of the work. Starting to develop mastery, peer-to-peer, relationship, peer-to-peer, program-to-program at those meetings. Folks are relying on one another. It was me out of coming in as the outside sort of mastery or expert and moving them into mastery of their own learning collaborative and their own work. I think that's incredibly important for sustainability, as well as continuing to adopt these programs into their own communities in ways that work for them. It also promotes resiliency amongst them and autonomy, which is a high value in many rural and frontier communities, is a sense of autonomy. And then we're also looking at how do we adapt the CHR practices to rural and frontier communities, what kinds of adaptations need to be made. There will be more cases of CHR than FEP, so those folks we're gonna need to work more closely with how that work is going. I don't think we can ever figure out how to streamline tasks more. I don't think we can ever have enough attention to streamlining tasks in rural and frontier communities. And then there is an intent to continue to promote regional capacity to take over some of their own technical assistance. So you would have in-community leaders providing more of the technical assistance and taking that lead. That'll probably be over the next few years. That's a summary of the content of what I had for so far. I know that there were some questions around models, stigma, and staffing. I want to see if those are still there and open it up to any other questions that folks might have, or comments, feedback. I'm really open in this conversation with you all.
Thank you, Katie. Yeah, please type your questions in the chat box or any comments. Katie, I have a question. Could you talk a little bit for those of us that are not familiar with the roles and the typical staffing structure for the EASA programs, what those look like?
Oh, yes, of course. Thank you for asking that. For sure. So the EASA programs typically have a lead of the program. Usually that lead person is also the gatekeeper for the program, and what that means is they're often doing the lead in screening, so doing that initial evaluation and assessment to engage with the young person and family to see if EASA is the right treatment fit for what's bothering them or the experiences or symptoms they're having. We have a licensed medical provider that we need everyone to have rapid access to when they come into the program. That's based on the need if somebody's in crisis, stepping down out of a hospital, but also there needs to be access for individuals who are choosing to not take medication and establish that relationship. We have case managers, case management needs, nursing needs, clinical supervisor needs, so we need our clinical supervisors to be sensitive to early psychosis work, innovations, working with families, working with young people, working with our specific practices and interventions. Somebody taking the lead on support and employment and support education services. We have more and more a need and for peer support specialists stepping in. How do we protect their time to do what they're trained to do and want to be doing on the teams? I think I said nursing functions. We have sensory assessments and evaluations that occupational therapists might do, and then people providing counseling. And the counseling services don't all require master's level. Certainly to do psychotherapy, you need to have a master's level degree, but our counseling includes relapse prevention plans, strengths assessments, engagement, a number of different interventions and supports that don't require a master's degree. So that's typically covered across the team.
That's really helpful. And could you talk again about, because you gave, I think, one example of what a role a nurse typically fills, but it was filled by someone else. Can you give us another few examples of kind of how the rural or frontier areas have utilized staff to cover these different functions?
Yeah, absolutely. Thanks for the question. So with the nursing functions, some are engaging nurses to do the nursing job, which is great. No problem there. Full support. For other sites, some of our nursing functions include education around reproductive health, education around nutrition and exercise and smoking cessation. If there's somebody on the team that is either already trained, knowledgeable, or interested in providing that education and coming up with some goals with folks and doing an assessment to evaluate what their needs are, that's great. We want to support that to happen. Some of our, one medical provider is covering smoking cessation and nutrition, but not exercise and reproductive health. So then we need to look at who on the team is going to cover what the medical provider isn't covering. So those are some examples, and hopefully you can hear how it's going to be unique to each site, each staffing pattern, and then deferring to the medical provider's wishes and time and comfort level.
Thank you. And I think we do have a couple of questions in the chat box now. Kayla's asking, where do you get your funding? Is it the CMHS block grant, or oops, I lost the rest of that, or the federal CHRP grant? So what's your funding?
So the EASA, yeah. Well, that's a great question. So the EASA Center for Excellence, most of our funding comes from the Oregon Health Authority goes to our OHSU. So our Center for Excellence is funded, and then the programs, and then we have been working on a 5-year research grant. But the EASA-specific programs come from the Oregon legislature through the Oregon Health Authority, is my understanding. And then I think some of them have CHRP funding as well. Our EASA programs, they'll all do CHRP work. So EASA covers both, and then there's some additional funding going on in a couple of counties, I think, for CHRP, or maybe one county. So there's the EASA programs, and then there's the Center for Excellence.
Great.
Let's see, the funding sounds fairly centralized. Is that true? Yes. I think that's my understanding. I'm not the expert in that. Our director would be, but it is. I think we're really fortunate in Oregon is that the funding is fairly centralized, and we've been authorized to support the rollout of the same fidelity model across the entire state. So we have consistency. It helps us to organize and titrate our own resources and get some consistency across communities. I think that's good for resource management, but also because in EASA, when somebody enters an EASA program, let's say they enter an EASA program in the county I live in, which is Deschutes County, and EASA lasts for 2 years, and in the course of the 2 years, that person graduates from high school and goes to school in Portland, which is Multnomah County or Washington County. They're going to be able to walk into an EASA program in another county. So the program model is supposed to facilitate and support how young people and families actually live in the world and provide equity and consistency in the best care possible. See, we have Zani. Hi, Zani. Thanks for the...
I think Kristen also had a question about whether you've had any experience navigating across private mental health provider system versus public provider systems.
Navigating across private. I have not worked with private mental health provider systems, like contracted. I know there are EASA programs that have. It's not, I've only worked in the public system as far as EASA goes.
And Zanny's comment, just a comment, I've only recently started a major role on an EASA team. The regional meeting I attended and a training specific to Eastern Oregon were crucial in giving me context and grounding provided from other counties on how EASA really can succeed in rural communities. That peer-to-peer learning is always so impactful. And Tamara says all funding flows through Oregon Health Authority except insurance and local grants. We have centralized outcome databases. We do also get both MHBG funding and CHRP in additional to OHA. CHRP funding is only in Lane County now. Thanks to Tamara for that clarification.
Hi, Tamara. Thanks.
Are there other questions that folks have?
I think there was one that was earlier around stigma, and I wanted to speak to what I know. I'm not going to feign to be an expert. I know I learned from SAMHSA that, and I like this terminology, taking a look at negative social attitudes and discrimination around these issues and mental health. And what I'm starting to do with that question is really do my best to listen closely to what the concerns rural and frontier providers are having, both in their role, but also the knowledge they're bringing in as community members about what kind of negative social attitudes exist in the community. I know that when we train and provide technical assistance to folks on community outreach and education, we have an entire template for folks to go through that actually deliberately asks them to identify what's going to be the argument against or the offense of presenting this information to any community group. So we deliberately ask people to think about it, write it down, and plan to address those concerns, beliefs. An example of that, I was talking with a couple of providers who were going to do outreach to faith-based groups. And they brought up a concern and saying they know that the faith-based group it's really important that the faith-based group to take the lead in healing challenges, concerns, problems that come up for young people and families, and that it was going to be really offensive for EASA to come in and say, oh, we'll take over, we know this better than you. And so we talked about how to genuinely say, we know and want to honor and need to learn from what you do that is so effective for your community members. And then to actually scaffold the EASA message into maybe being smaller than we're this 2-year program and we can offer all this support, which a lot of us get really excited about, myself included, and just say, you know, it sounds like you cover family support, you cover social support. Here's a couple of things that EASA might offer that it sounds like you're not able to do right now. What do you think about letting us try offering a couple of additional supports just to make what you do go even better? So it's really changing the messaging to lift up and honor the values and the work that other community groups are doing, which hopefully when we can get people talking to us that way, we can get more at what are some of the negative perceptions and attitudes towards young people and their families. But I think we need to start with a backup and just evaluate how are we being perceived in the first place as providers, and then build some trust and move in from there. I think we could do a lifetime of research in that field and continue to learn. It's one that I have particular interest in. Let's see, so there's more, let's see. Kristen says, Kristen Woodbury, I'm also interested in whether you have partnered with other rural health efforts or whether the early psychosis efforts are independent of other services. In Maine, there seem to be a lot of HM service delivery, so that planning over a number of years feels particularly challenging. Mental health. Thanks. Got it. Thanks, Kristen. A lot of changes in mental health service delivery. So EASA's been around for quite some time, about 20 years. Partnered with other rural health efforts. I think I might be, could you tap just a couple more clarifying points in there, Kristen? I think I'm getting at what you're saying, but I don't want to miss the essence of it. Are you working with broad mental health services? Oh, I see, thanks. Working with EASA specific, not broad mental health service delivery. However, because of some of the EASA adaptation and implementation going on in the frontier, that's affecting how other service delivery happens and changes in care. I don't know that this, so I'll give you an example. I was out at a frontier site doing a fidelity review, and we had talked about including the cultural formulation interview into clinical supervision for the EASA. EASA team members. The cultural formulation interview is in our newest diagnostic manual. How the questions to ask are more culturally informed and humble when engaging in assessment and treatment planning with folks. The team and the supervisor went ahead and looked at the cultural formulation interview and decided it was a vulnerability across their entire agency, trained everyone at their agency in the cultural formulation interview, and implemented the use of that tool in every assessment, including their electronic health records and across all clinical supervision. So we just had an EASA conversation that affected agency care and service delivery and knowledge. So I think that I could come up with a number of examples like that. There's another one where the EASA team is working directly with a primary care provider and coordinating more closely while folks are actually enrolled in EASA rather than at discharge to really look at bridging more robust healthcare support during their time. Yeah, amazing leadership, right? I'm going to give them credit. New Directions, Baker County, Oregon, they failed 4 fidelity reviews. And this is what they're still doing. So I'm so impressed with them, and it's just such a privilege to support them and their innovation. Absolutely amazing leadership. They're a county of 16,000 people. Almost all live in a very small area, and the rest of their county is unincorporated in townships. So very exciting work. Very exciting work.
See Tamara's typing. Does anybody else have any additional questions as well? A couple of folks, give them a few minutes to get their thoughts in.
Great.
Tamara says it's helpful that most of our rural frontier communities are part of a common network. What does that stand for?
That's the Greater Oregon Behavioral Health Initiative. That's the coordinated care organization.
Okay.
So they already have a relationship. And if they haven't worked directly with each other, they have colleagues that have worked on a RAP team together or an ACT team together and met. Do you have any EASA programs outside of this network? EASA is in outside of Oregon, Kristen? Yeah, so there's EASA programs in every county in the state of Oregon, with the exception of maybe one and a half. So EASA is a statewide rollout into every county. Same model, same training, same Center for Excellence. We support the whole state.
I work with Kentucky, Utah, Alabama, and Colorado now, but they're all developing their own hybrids. That's good to know. Very interesting. That's a diverse array of states right there, very different cultures. Interesting.
Yeah.
I'd be interested
I think one of my recommendations, whoops, sorry. I'm sorry.
No, it's just interesting to see what they come up with to customize it for their own states.
Yeah, I think it'll be interesting around customization based on community to community. I know that's what's been necessary in Oregon is one frontier county to the next. They're not the same, just like no urban county to the next is the same county or community and have the exact same resources. So it'll be interesting how and who provides the ongoing consistent training and technical assistance to the teams where that rapport can be built, and then the fine-tuning of adaptations can be made as people move from very beginners and moving towards mastery stage. It's going to be interesting to see. Who created the EASA Center for Excellence? Oh, I'm so lucky our director is on here. Tamara Sale can type away. Thanks, Tamara. And I would be remiss to say the Center for Excellence exists because of the young people and families that have trusted us to help them through incredibly difficult times. So there's, of course, funding.
Your call. Participant lines muted.
Weren't willing to give us a chance and trust us. The work wouldn't happen or it wouldn't sit or stay within the communities where it belongs. And it's just an incredible honor.
Yeah. And Tamara agrees. That's terrific.
It's really, it makes us relevant that people are willing to give us a try.
Yeah. All right, last opportunity for a few questions. If anybody has anything else on their mind they want to pick Katie's brain. This has been so interesting.
Yeah, thank you, Tamara. It's really helpful to have a central effort. Really helpful. coordination, consistency, double backing, checking, gathering resources. It's been a really great model. And you're so welcome.
Yes, thank you so much, Katie. That was just really informative. And we really appreciate you giving us some time. And so, and there's Tamara says, we're so lucky to have Katie. I think we all
Oh,
do.
well.
So
Now I'm successfully embarrassed on a webinar. Okay, thank you.
Well, this a link to this video recording will be sent out as soon as it's ready, and it will also be available on the TA Network's Ideas at the Institute Learning Collaborative platform, as well as the slides, which you can also download out of the files box right now. So thank you to everyone that joined, and thank you again, Katie, for sharing your experience with us. And I
You're
think we
so
can
welcome.
Good. All right. Well, thank you all, and please stay just a few seconds to fill out the survey from the right here. If you could, are you going to put it up, Tiara, the survey?
Well, that
there
comes
it
up.
is.
Thanks
right
so
there.
much for inviting me and having me. Really, really honored. It's a privilege. Thanks.
Oh, thank you. It's an honor to have you. And please, everybody who could take the survey, we appreciate it. Thank you. All right.